Hello, everyone. We are so excited to see so many faces here in this room, or names in this room as your videos are coming up. My name is Valerie Aceta. I am the president-elect of our Alabama chapter of the Voice Foundation. I'm going to share my screen as we're bringing some more folks in just to do a quick hello, and then I'm going to hand it over and start this really exciting presentation and chat. Let me share this. These are the beautiful faces of our leadership team here at the Alabama chapter of the Voice Foundation. We have a few of these humans in the room with us. Edie Hapner, of course, is our past president. Elizabeth Benson, our current president, and Molly Adams, our membership director, are all here in the room. We really love this community. We do probably every other month, we offer a presentation or a topic that we present to our community. And we're very excited about the one that we have today. So I do encourage you to save the date for our next meeting, which will be Sunday, October 13th at 5 p.m. We will be sharing the content as soon as we have that. So keep an eye out on social media and on your emails, and we will share that with you as soon as we have it. We are, again, so thrilled to have Dr. James Callaway with us today. And I am going to share just briefly his bio with all of you so that you know how lucky we are to have him with us today. Dr. James Callaway is an assistant professor of medicine and otolaryngology at the University of Alabama at Birmingham and serves as the second section chief of the gastroenterology at the University at the Birmingham VA Medical Center and is the director of the Esophageal Function Lab at the Kirklin Clinic of UAB Hospital. He received his medical degree from the Medical College of Georgia and completed his residency at UAB, where he served as chief medical resident. He remained at UAB to complete his gastroenterology fellowship and is board certified in both internal medicine and gastroenterology. He has an avid interest in the clinical education of both residents and fellows. His major clinical interests include dysphagia, esophageal motility disorders, esophageal strictures and gastroesophageal reflux disease, and its complications. So we are so excited to have Dr. James Callaway here, and I'm going to turn it over to him.
Yes, thank you very, very much. Let me make sure I am. Okay. Are y'all now seeing single slide? Awesome. Well, yes, thank you everyone very much for having me. Yeah, so I'm James Callaway. I am, first off, not an otolaryngologist, and I'm not a speech and language pathologist. So two things to know what I am not, but I am a gastroenterologist that has a big clinical interest. I'm basically Alabama's main esophagologist. So all I really deal with is kind of here to here in the world of my clinical work day to day. So Edie asked me to consider talking to you guys actually about reflux and dysphonia, and it was something that comes up a fair amount in my clinics, and I know probably in y'all's world as well. And so I thought we'd try to look and try to dive a little bit into reflux disease and the voice. And the way I'm going to do this is I'm going to actually first start by clicking a button that goes there. Yes, we are going to at least initially start talking about the basics to reflux disease. I know not everyone here is a physician or is a physician at all, but I want to talk about reflux disease and what it is in kind of its truest form. And then we're going to talk about the plausible relationships between reflux disease, dysphonia, and then we will talk about some of the limitations of the data that we have there. And also, please give me some grace if I say some words that are like not in the speech pathology world, or if I start mixing up weird things like hoarseness and dysphonia and raspiness and things like that I really don't know what they are, but at least I try to talk with my speech and language pathologist here at UAB about as best as I can. So here we go. So reflux disease, just at its basic, is defined as symptoms or complications resulting from the reflux of gastric contents either into the esophagus or beyond. And beyond is into the oral cavity, including the larynx or the lung. But primarily, reflux disease is at least initially thought of as typical symptoms, which are heartburn and regurgitation. Patients that have that typically after meals. It may be a burning sensation, but obviously there are atypical symptoms as well, which is why I'm actually here today to talk about how that, what that means or what that looks like, and how does that relationship, or how do we deal with that relationship or think through that relationship. And we're going to talk about some interesting overlaps between the laryngeal world and the esophageal world with regards to neuromodulators and hypervigilance and neuroreceptors and things like that, that really crosstalk a fair amount and make a lot of the things that I deal with every day in the esophagus very similar to the things that you guys may deal with in this space, the neck space, and the larynx. Okay, so this is a slide looking at the prevalence of reflux disease, and I guess the main thing to note here is that reflux is really common. Now, this is again the best data we have, at least worldwide data, but pooled prevalence is 13% of the world has reflux disease. And if you look at the United States, we are in the yellow, which is the 15 to 19.9%. And it really is probably the most common condition that we see in GI clinics. That and irritable bowel syndrome kind of go back and forth on what patients are presenting with the most to us. Would be symptoms of at least weekly reflux disease, or weekly symptoms of gastroesophageal reflux or IBS. But it's a super common thing that we see in our GI clinics. It's also something that's pretty commonly seen in the ENT clinics as well. And so many times these patients may be coming from, or I may get referrals either from ENT, from pulmonary, from our speech and language pathologist here at UAB. And so it's a wide array of, I will say, of clinicians and physicians that actually may be helping, at least in the management of this condition, or at least be exposed to patients that are presenting with complications or signs and symptoms of something that this disease, gastroesophageal reflux disease, may be affecting. So biggest risk factor for reflux is obesity. And specifically in central adiposity are two big things that are biggest risk factor for that. And this slide here is showing on the y-axis the mean number of reflux episodes, and then looking at weight across as BMI's normal weight over to overweight to obesity, and the number of both acidic and also non-acidic reflux increases as obesity goes up. And this is a big deal because we live in a state called Alabama, and Alabama, unfortunately, is one of the more overweight states, and so reflux disease tends to have higher proportions here, and that is something that is notable for our patient population. Interestingly, randomized trials have shown that reduction in weight can reduce GERD symptoms and actually esophageal acid exposure times. And I'll go over acid exposure times a little bit later on, but that's kind of how we objectively, at least in the GI world, define if someone has an abnormal or pathologic amount of reflux disease, or these what's called esophageal acid exposure times. And interestingly, I found a study just from a few years ago that LPR, laryngopharyngeal reflux, that phrase that many of you definitely have heard, also increases with obesity when they look at impedance and pH studies as well. And there tends to be a linear relationship as BMI goes up. LPR symptoms tend to increase as well. So I say that because when it comes to the management of this, one of the things that at least myself as a physician is always recommending to patients are what types of lifestyle modifications can be made that could help my symptoms, and weight reduction. Although that would seem kind of odd in the world of maybe a treatment of voice-related reflux or a reflux that could be associated with dysphonia, we do know that there is a decrease in reflux in general with weight reduction. All right, so how does reflux occur? And then I hopefully can relate this slightly to maybe the world of voice-related or even singing. So the majority of reflux is actually transient lower esophageal sphincter relaxation. So there's this muscle at the very bottom of the esophagus, which stays closed all the time, and then it can relax transiently. When it relaxes, typically after meals, when the pressure in the top of the stomach starts to overwhelm the pressure of that sphincter, when it relaxes, then it allows for reflux to go in an upward position up into the esophagus. We know the patients that have a low baseline lower sphincter pressure tend to have more reflux than others. And we know that that lower sphincter does relax with swallowing. So when we are swallowing, we are relaxing that lower esophageal sphincter, which can not only does it allow food to go into our stomach, but it can allow things to come back up during meals. And typically, straining during periods of low LES pressure, especially right after meals, is another big factor that it comes with reflux disease, or a thing that is contributing to reflux disease. And one of the things I'm going to show here in a little bit when we look at reflux tracings is that the majority of reflux, when it occurs, is actually right after meals. That first 45 minutes, maybe hour after meals, is when the majority of reflux occurs. And that's normal. That's actually physiologic in nature. So having at least some reflux symptoms may not necessarily be abnormal in certain patients. When it becomes troublesome or when it starts causing other types of problems is something for us to think about. I did want to bring up hiatal hernias. This is a question I get a lot about because these are seen frequently on endoscopies or CAT scans, things like that. And hiatal hernias is where the top of the stomach kind of pushes up through the diaphragm, and that also does result in an impaired reflux barrier. The reflux barrier, the diaphragm, and that lower sphincter are supposed to be right at the same spot. And so ideally, when they're working together right at that level, I guess they're the most effective reflux barrier. But when they are not in sync with each other, when the lower esophageal sphincter is moved towards the head or moved into the chest, the diaphragm and the LES are not at the same spot, and so that can be a setup for reflux disease. What's odd about this is we see hiatal hernias all the time, at least on imaging, or patients who are told they had a hiatal hernia at some point, but not all these patients actually have pathologic reflux or even symptoms. We see it quite frequently, and patients may or may not have any symptoms of this, but they can get larger over time. They can actually get quite large. Some patients have their entire stomach up in their chest because it's herniated up in there. And those patients obviously can have lots of reflux disease or lots of symptoms related to that. But having small hernias are not uncommon. All right, so talking about the clinical symptoms of reflux disease, I mentioned the classic symptoms. And so that is pyrosis and regurgitation. Pyrosis, think fire. So think heartburn. So that is the burning sensation in the center of our chest. And regurgitation, which is that sensation where we feel like acid's coming into the back of our throat. Those are the classic symptoms of reflux disease. We have recently added esophageal chest pain, which is kind of a nondescript chest discomfort, to our list of typical GERD symptoms. And those, when present, allow us to potentially just empirically treat patients with reflux medications without asking a whole lot of other questions. I.e., if you can actually go over the counter and go to your local Costco and you can grab 14 days of Nexium or Prilosec, and it says, hey, if you have frequent or infrequent heartburn symptoms, take this for 2 weeks. And that is reasonable in patients that have very minor symptoms for them to do that. The question is, should we be doing that when patients start complaining about a hoarse voice? And we're going to talk about that today. Less common symptoms of reflux disease would be dysphagia and odynophagia. Again, that is difficulty swallowing or painful swallowing. Water brash is kind of hypersalivation that can occur when reflux is occurring, and patients often say that it tastes acidic, but it's really just hypersalivation. But when mixed with stomach acid, it can taste acidic. Burping, nausea are symptoms that also have been reported. Now, extraesophageal manifestations are different. So other things that have been linked to gastroesophageal reflux disease, including laryngitis, chronic cough, pneumonitis, dental erosions, disordered sleep, dysphonia, asthma. These are what are called extraesophageal manifestations, which have clear association links to them. What is more difficult in each of these scenarios is the causality on clearly saying that your asthma is definitely caused by reflux disease, or your dysphonia, your hoarseness is definitely caused from reflux disease, is one of the tricky things that comes up in my world and y'all's world, actually. And so that actually brings up the differences between association and causality. But these extraesophageal manifestations are there, and they're clear because some of them actually do respond to anti-reflux treatments. And so that's where we know that there can be some linkage between these extraesophageal manifestations, and we are aggressive at treating them. especially if the symptoms are responsive. So how do we diagnose reflux disease? I mentioned the empiric trial of acid suppression. So these are the things that you can get at your pharmacy that many patients will just start taking on their own. Up to 2 weeks is the recommended treatment for each of these trials here. At least on the package inserts for all of these, it's supposed to be 2 weeks is the max course, but of course patients take this longer. And in many cases, that's okay. In many cases, that's probably not advisable or recommended. But this is one way that we actually diagnose reflux disease. If you have typical symptoms, trying empiric trials of acid suppression is actually cost effective. There's a low, doing 14 days of reflux medications is okay for many basic reflux symptoms. It's probably not okay for the voice because if we are treating reflux related voice changes, if we think that's the main cause for it, the typical recommendation would be higher doses and longer durations. And so we're going to kind of get to that if we actually are treating at least extraesophageal symptoms of reflux. Now, of course, endoscopy is something that I do in the world of diagnosing reflux disease. And this is actually taking a camera scope actually into the esophagus and looking. This is not doing a laryngoscope. I'm not just looking in the back of the throat here. I'm actually looking in the esophagus to actually assess for damage. But this is a way that we can diagnose reflux disease. And then the thing that I'm going to speak about a fair amount over the next hour is ambulatory pH testing. And this is basically different types of monitors that can be done, put in the esophagus to measure and quantify how much reflux is going on in a particular patient. There are two major flavors for this. Both of these are offered in our function lab, esophageal function lab here at UAB. The one on the left that you're looking at is the pH and impedance probe. It's a small, thin probe that sits in the esophagus. Some of our probes actually have a gastric portion, actually go all the way into the stomach. Most of them just stop in the esophagus, and they have multiple sensors on them that can actually diagnose or quantify reflux that's going up the esophagus. You can actually either measure just the pH changes, so changes, remember from chemistry, changes in pH, or it can actually measure volume of liquid actually going into the esophagus. The one on the right is the Bravo capsule. It's another implantable device that will put in patients' esophagus. And it actually almost is like a Wi-Fi. You wear a little monitor that it hooks to, and it will be measuring and quantifying how much reflux is going on over a 48, 72, maybe even 96 hours if we're trying to quantify how much reflux is going on. That's just a picture of the box for the one that hooks through the nose. But patients actually will press buttons on there. They'll tell us when they're eating, they'll tell us when they're sleeping, and then they will also tell us when they are having symptoms. And that allows us to kind of quantify and temporally correlate, is there coughing or is there throat clearing? Does that actually have a temporal relationship to their reflux? Is there a clear association there? So that's how we typically utilize this type of testing when we're trying to objectively define reflux disease. So this is what a study may look like. So this is a probe that's in the bottom of the esophagus, and then I get a printout over a 24-hour, 48, set up to 96-hour period of how much reflux is going on. So we, again, will look for changes in pH. So we're defining reflux as when the sensors actually define acid in the bottom of the esophagus. This is how we define individual acid reflux events. And then we can, as I mentioned, quantify that by when the patient is sleeping or when the patient is not sleeping. This is actually a pretty typical tracing right here. One of the things that you'll notice is that reflux, again, doesn't drop below that gray line in the center very often or even really at all at night. And this is typical of most patients. So reflux tends to stop at night. And a lot of that is because of that kind of physiology I said earlier, right? After meals, when the pressure is high in the top of our stomach, is when things tend to push on that lower sphincter, allow it to relax, and then allow reflux events to occur. So most reflux is a postprandial event, meaning it occurs in that first 30 minutes to an hour after meals. And when we lay down at night, it tends to, again, we tend to swallow a lot less. It tends to be, obviously there's some variability of the pH that's seen there, but actual acid reflux events, so the drops of pH less than 4, which is how we define acid reflux, are actually quite uncommon in patients at night. Now, when they occur at night, it's a big deal usually because you're laying down flat. And so when reflux does occur, it tends to be more complicated. When I say complicated, and I'll show some slides of that here shortly, it's more likely to produce erosive esophagitis, meaning when we go in there, look at the esophagus, we can see active inflammation and damage or ulcers. So kind of two different worlds that I look at and how I'm looking at reflux disease. Is this non-erosive disease, more likely to be female, young, thin, no hernia? So when we go and look at their esophagus, it tends to look pretty normal. Versus erosive reflux disease, more likely to be older, overweight males with a hiatal hernia present. They're much more likely to present with actual ulcers in their esophagus compared to a more normal appearing esophagus. So these are the big complications of reflux disease. And I know we haven't got to the voice much yet, but we will get there, I promise. This is the last couple of slides. But in the world of reflux disease, so reflux esophagitis is something that is important to us because this is the actual inflammation that we see in the esophagus. And when I see this, I'm much more apt to think that a patient could be having extraesophageal symptoms as well, whether or not that is voice changes, whether that is a globus sensation, whether that is throat clearing, whatever they are presenting with. If they have reflux esophagitis along with it, then that is much more likely that actually is a causal relationship there, or much more likely that the treatment of that reflux disease may actually help their extraesophageal symptoms. So these are some pictures of those. So this is a really eaten up esophagus from bad reflux disease. This is very mild reflux disease, kind of mild little ulcers at the bottom. But if you look at the very bottom, there's a narrowing that's there as well. And that's a stricture from chronic inflammation disease. And that patient is much more likely to have difficulty swallowing. Barrett esophagus is something that gets a lot of press because that's actually a pre-malignant condition that chronic reflux disease can lead to, that then could potentially turn into esophageal cancer, which actually does come from chronic untreated reflux disease. Interestingly, patients with esophageal cancer, only about 50% of them actually have symptoms of heartburn or reflux prior to their diagnosis of esophageal cancer. So it's a poorly understood phenomenon, which does speak to the differences in sensation that we have in our esophagus. And this is going to actually crosstalk a lot with the larynx because there are definitely people that are just more sensitive than others when it comes to their laryngeal sensory or their esophageal sensory. All right, a couple of slides on treatment of reflux disease before we get into the voice, which is, and I guess I want you guys to pay attention at least to the lifestyle changes regarding this, because this is simple things that anybody can do that doesn't require a prescription. These are things that at least some of these things actually have data behind them. And at least obviously there's a lot of tales out there of what could be done for reflux disease, but we can treat these things medically, which we talked about some of those medications, lifestyle changes, and then there are surgical treatments for reflux disease too, which may be necessary in certain patient populations. So 2 slides on lifestyle modifications. This is more of a, I guess, not a summary, but things that have been looked at from a systematic review standpoint. Weight loss, as I mentioned earlier, does decrease esophageal acid times. So it actually can decrease the amount of time that your esophagus is exposed to acid. In 2 different randomized control trials, weight loss has been shown to do that. In normal weight individuals, tobacco smoking cessation also has been shown to reduce reflux symptoms. So 2 easy things that can be recommended to patients to try to treat reflux disease. Nocturnal reflux, late evening meals. So if we eat late at night within 4 hours of going to bed, that increases our supine acid exposure compared with early meals. So avoiding or trying to have extending the time between your last meal of the day and actually laying down at night actually can decrease supine reflux, which is important because I mentioned supine reflux tends to be more complicated or more likely to be erosive in nature. And then head of bed elevation, HOB, head of bed elevation is also a simple thing that can be done. And you guys may have heard of things like reflux wedges that can be sold at medical supply stores and that actually just elevate the whole torso, the head, not just the head of the bed, but actually really from your torso up to how to let gravity kind of work in your favor. These are, and this was from 2 years ago in our GERD guidelines, the reflux GERD guidelines that came out that actually was trying to look at the scientific evidence behind lifestyle modifications. And this is really just a slide to kind of keep because it really goes through what kind of evidence do we really have that avoiding fatty meals or avoiding carbonated beverages or decreasing caffeinated beverages actually is helpful. And most things actually are recommendable. The only thing that came up on here that was not recommendable was avoiding alcoholic beverages, interestingly, because the scientific evidence behind that, it was not well understood. And pathophysiologically, we couldn't really conclusively say that decreasing alcoholic beverages is going to help. At the same time, I clearly have patients that say that red wine is their kicker every time. And I'm like, listen, if that's your trigger, you need to stay away from that because I know it gets me. So if it gets you too, that's okay. Let's avoid that particular trigger. The one thing on here that has very good evidence behind it is at the very bottom, which is sleeping on the left side. So actually the left lateral decubitus position actually has really good data at decreasing reflux disease, especially nocturnal reflux. So if that tends to be a problem, sleeping on your left side is one thing that actually has really good data behind it and is something that's easy and simple for us to be able to recommend to our patients. Avoiding excessive exercise I thought was kind of interesting because we do know that I'm a runner myself, and running actually increases reflux too. And whether or not that's just putting increasing intra-abdominal pressure on the diaphragm, I thought about in the same world of singing too, because I don't know if anyone's actually ever looked at, prolonged singing. What exactly does that do to the diaphragm? And exactly if someone's had pH probes during long singing exercises, what that actually does. I think it should be done, if not, because it would be probably a pretty easy study to do, although maybe uncomfortable. But I do think that it's an interesting thing that should be looked at because pathophysiologically it would make sense if we are putting large amounts of pressure on our diaphragm for prolonged periods of time. Okay. So this is a good slide really for my fellows and residents to look at because this is actually showing how are PPIs helpful. And really what we know that PPIs, so proton pump inhibitors, these are Nexium, Prilosec, medications like that are sold over the counter, but these are our mainstay of medical treatments for reflux disease. Where are they helpful? And what you're looking at here is anything that has a long green line means that we know PPIs are really helpful in helping that reflux problem. And at the very top are all the typical problems from reflux. So esophagitis, that's inflammation of the esophagus, healing heartburn are two big things that we know that reflux medications are really good at. Things that they're not as good at is actually regurgitation. Reflux medications like Nexium actually don't stop you from having reflux. They just make it less acidic. So you're still having reflux going on. You're just having weakly acidic things go up and down the esophagus and not acidic things. And the weakly acidic processes tend to be less noxious and tend to be less problematic for our esophagus and also for our larynx to be able to tolerate. At the very bottom, you're going to see chronic cough and you're going to see hoarseness down there. Unfortunately, the green lines there are not really good. And the reason why they're not very good is, I guess, the chronic cough, interestingly, that one's actually sorted out by positive pH or negative pH. And that means they've actually been conclusively diagnosed with reflux disease. And maybe in those that actually have documented acid reflux disease on pH testing, those patients tend to get a little bit better benefit, but look at the therapeutic gain. It's like only up to 25%. So it shows you we really have limitations with the available acid reflux medications that we have and how good they are at actually helping symptoms. You're going to look that there's just not great data in the world of hoarseness and dysphonia for the treatment of PPIs. And I'll go through this is a slightly older slide. This is probably 10 years old. And I will look at the randomized controlled trials, or at least talk briefly about those of PPIs and the use of voice changes. I did want to bring up alginates because this comes up a fair amount. This is something that also is over the counter that I actually do recommend to my patients frequently, especially in extraesophageal symptoms or in persistent reflux symptoms that has not responded. And alginates are medications. So Gaviscon Advanced, and there's something also called Reflux Gourmet, which are basically these products that, and think algae here, so alginates. These are medications that actually form like a raft on top of the stomach acid pocket when we eat, and it just kind of sits there. And so when reflux tries to occur, it almost is like, I'm going to use the word pond scum. It literally kind of creates this barrier that doesn't allow things to go up because it creates a barrier for that. Again, these are over the counter. Gaviscon Advanced has a high potency version that can be found on Amazon. And I mentioned Reflux Gourmet, which is another one that, again, also tastes a little bit better actually than Gaviscon Advanced, which have been shown, at least in one study, that they can actually help with heartburn symptoms. And this can be taken after meals and right before bedtime. Now, when we look at all the randomized controlled trials, though, unfortunately on alginates, there is a trend toward benefit, but statistically significant differences have not fully been documented. And this is for RCTs that actually are looking at the use of these medications, again, called alginates, and that's Reflux Gourmet and Gaviscon Advance. And they're just not, they're not perfect for that. They're helpful, and I recommend them frequently because they can be gotten over the counter. You can get them on Amazon. Some patients really like the sensation of taking something after a meal. They feel better about that kind of active process of trying to treat their reflux disease. And these medications are otherwise very harmless. And so because of that, they're an easy medication for me to recommend to patients as an over-the-counter adjunct to their other reflux things that they're doing, whether that's lifestyle changes or whether that is medical therapy or even surgical therapy. So I'm just going to briefly kind of go over surgical things, just two slides here, and then we're going to get into the voice. One is fundoplication. I say this because you may have patients that have had these done before, and so just for you to be aware about. But a surgical fundoplication is where the surgeons actually go in and wrap the top of the stomach around the esophagus. And this is an attempt to basically make a barrier to prevent reflux from being able to go proximally again. This is done laparoscopically at this point, and the recovery is usually not too crazy from this surgery, but it's also not the easiest surgery to go through. It is a laparoscopic surgery. There's a few days in the hospital, and we really kind of pursue these patients typically when there is a hiatal hernia present as well, where they actually will pull the stomach back down into the chest, and they will actually wrap the stomach around itself, not only to prevent it from going back into the chest, but also to create a reflux barrier. I'll combine that with, this is the picture from their website of Lynx. The Lynx device is actually this magnetic set of beads that go around the bottom of the esophagus that also basically help augment the pressure right at the lower esophageal sphincter, also in a way to hopefully prevent acid, which is depicted here as radioactive material on their website, going back up into the chest. But this is another at least surgical approach that has gained a lot of ground actually, because it is less, you're not changing the anatomy of the stomach nearly as much with this type of treatment. Okay, reflux disease and the voice. And the way I wanted to at least start with this is I wanted to start with a study out of this is from the Vanderbilt Voice Center. And then I say that Mike Vasey is a gastroenterologist that was one of my mentors in the early part of my career, who I got to work with a lot in the world of impedance testing, but he works closely with his ENT guys as well. And so this was a paper from 8 years ago that was trying to kind of narratively discuss, have we truly established causality between voice disorders and reflux disease? And I thought it was really interesting. And if you get a chance to read this one, it's actually pretty good on how we think through it. But I'm going to go through most of it in narrative form over the next few minutes. But really what it boils down to is we know that reflux and voice changes are plausible. It makes sense. The larynx, the esophageal inlet, they are right there. We know they're the proximity of these things to each other is makes for some type of relationship. And so because of that, we have to at least acknowledge the fact that reflux disease can cause changes, or at least potentially can cause changes to our voice. Reflux disease, though, is physiologic. And that's something I want to get across. It happens in everybody. It happens if you've already had dinner tonight. You may be having some reflux now. You may not be feeling it, but reflux is physiologic. It is intermittent and after meals typically, as I've already mentioned. Reflux to the pharynx is also physiologic. It going all the way up the esophagus does occur, and that doesn't necessarily mean that it is pathologic. Our body is actually really amazing at the types of checks and balances and defense mechanisms that it actually has to be able to combat things like reflux coming up into the pharynx, but it's also physiologic. When it becomes problematic or when it becomes pathologic is when it actually starts to cause symptoms, or it starts to occur in a certain frequency that it actually is causing damage or problems. And that is a thing that's really interesting for us to try to figure out. And let me show that on at least numerically what that means. So what is considered normal in the world of reflux disease versus what's considered abnormal? So normal, at least in reflux testing, is less than 4%. So we're allowed up to 4% of our day, we can actually detect acid reflux, and that's considered physiologic. And pathologic is considered over 6%. So there's like a 2% difference in physiologic reflux amounts to pathologic reflux amounts, at least based on the studies that we have. And that's how we actually define pathologic acid reflux disease on objective testing, so objective measures. That is the Bravo testing that I showed you earlier, or that pH probe in the nose. That is numerically what we are looking at, and that's the difference between normal and abnormal is a 2% difference, which is really interesting because that number seems so small to me from a percentage standpoint. But it also shows you that our barriers or our defense mechanisms can only handle so much before other types of things may come into play. All right, so when it comes to the evidence for causality, and this paper kind of goes through these, I don't know, what is this, 10 different, 10 different different points of things that should be looked at when we're trying to establish causality. And they called it the Bradford Hill criteria, which is what they went through in this particular paper, was looking at if we are going to establish a causal relationship versus just an association relationship between any two things. These are things that we need to go through. And that is the big distinction here that they kind of really were trying to hit home, was that, yes, we know that there's an association between reflux disease and dysphonia. The question is it causal in nature? And that is sometimes very hard for us to define. But as scientists, we really need to think about that as we are trying to determine not only our treatments, but our research, and then also how we talk to our patients, because an association means one thing, but a causal relationship is a different threshold that something must cross for us to fully agree with it. Now, biologic plausibility is there's not really a question there. We know that. We know that how close those things are to each other. We know we've done testing. We found pepsin in patients' lungs, actually in their eardrums, or things that are found only in the stomach. We can find that in the inner ear, so we know it can get up into the nasal cavities and actually up into the posterior. I guess not the ear canal, but behind it. So we know that can happen, and so biologically, it is plausible. Like there's no question that the plausible relationship exists because of other multiple scientific studies that have shown that gastric contents have been found in the larynx, in the lungs, in the ear canals, in the sinuses. So that's not a question. Experimental findings have also shown that to some degree as well. We also know that, and then kind of going to the dose-response relationships, that's where things start to get a little trickier. We know in canine models, they've done things where they've actually shown damage from acid, like putting acid on the larynx and different levels of acid. And we know the more acidic stuff that gets there, the worse the disease is. So we know there is a dose-dependent relationship to acid reflux as it touches the posterior hyperpharynx and the laryngeal inlet. And we know that experiments just have shown that can occur. What gets harder is temporality, actually. Because for temporality, which is basically that the reflux should come before the dysphonia, that's the hardest thing to prove. Because for us to show a causal relationship, the reflux has to come first. And that, again, is very hard to prove in someone because they usually present with their symptoms. So how do I prove that they did or did not have their said symptoms ahead of time? And that can be tricky and almost impossible to do, because you would really have to have nasal probes in a bunch of asymptomatic people to then show over time, do they develop dysphonia, and then they can show that the reflux occurred before it. What's also interesting is that reflux is not something that typically just starts and stops. Unless you were to have like crazy weight changes one way or the other, most patients, at least in a short period of time, their reflux tendencies should be relatively stable. It's not that one particular meal that you had that was bad is going to make you have reflux disease for the next month. That's just not how it works. Physiologically, reflux is going on day to day in any individual patient. And some patients are going to have symptoms. Some patients are not going to have symptoms. And some will cross that threshold from physiologic to pathologic. But the temporality thing is actually one of the hardest things, I think, for us to really prove that the reflux came first. And that's what actually caused the dysphonia. Strength of association is tricky too. We usually are looking at PPI studies, and I'm going to go forward one slide with that. And this is looking at PPIs and their ability to improve voice. All right, so we have 8 randomized controlled trials that are PPI versus placebo. There's one that's PPI versus voice therapy, and then one PPI versus lifestyle changes. And as you look at this slide, what I want you to look at is if the bars are fully on the right side of one, then that is showing a definite relationship. If the bars cross that line, that is showing us that unfortunately that relationship is not shown to be conclusive. Okay. And so this is 8 different studies, 2 that actually showed an odds ratio that actually showed some association that PPIs could be helpful in voice changes and in dysphonia. And then I've got 1, 2, 3, 4, 5, 6 others that unfortunately could not show that same relationship. So going back here, that actually brings up a problem with consistency. So if I want to show a definite causal relationship between any one thing and another, I really should be able to show some consistency there. And unfortunately, in medicine and in science, we don't always see consistency in our research studies that we do. But when you look at studies like this, it starts to make us pause and say, all right, yes, they're associated, but is it causal? And that is again, at least Mike Vasey and the Vanderbilt group at least put a big pause, at least in their paper on, all right, yes, the association is definitely there. What is that strength of that association? And does it cross the threshold for true causality, or is it just an association? Okay, because if we look at it from an association versus causality, it may change how aggressive we are on treatment or how much skepticism we should have before we recommend to our ENT colleagues or to my GI colleagues that, hey, we should just put these patients on PPIs and just forget about it because that's what's best for their voice right now. Okay, and hopefully what I'm getting across here is that, listen, the data is not that good for you just to say everyone needs to go on PPIs every time they have hoarseness. It's just the data is just not that good. Okay, that's kind of go over consistency, specificity, coherence, and analogy are 3 other, I guess, links that need to be established that I'm going to kind of skip here. But hopefully I'm getting across that there are differences between association and causality that are difficult, at least in the scientific world, for us to fully establish. We know that they're associated, but that causality is tricky. Okay, why? Why is it important for us to make that distinction? So this is a study from a couple of years ago over in Europe that looked at just the empiric use of proton pump inhibitors to treat persistent throat symptoms. And this was in ENT clinics and family practitioners. I think it was mainly ENT clinics. And so in this study, multi-center, double-blinded, randomized, placebo-controlled trial, which means that they took patients and they either gave them placebo or they gave them anti-reflux medications, and they looked at their reflux scores. And these were patients presenting with throat symptoms. Okay, and it didn't clearly say this was all dysphonia, but dysphonia, throat clearing, globus sensation, kind of a fullness sensation that's there, and repetitive kind of throat discomfort. And they were randomized to one versus the other. And at least in this study, the patients that got put on PPIs, they all tended to do worse. Their symptom scores got worse compared to their symptom scores getting better. And so before we just jump and just throw patients on any type of medication, or at least recommend a medication for it, we need to think, all right, have we established a true relationship to that, especially when there maybe even is potential to harm. Now, reflux medications in general are safe. I don't want to totally say that they cannot be used, right? They're sold over the counter. So if they're sold over the counter, they should have some safety profile that the FDA has allowed, but it's usually in small amounts, right? I mentioned 14 days. And I also mentioned that if I'm typically treating a patient that I think has extraesophageal manifestations of reflux disease, I use double dosing, so high dose reflux medications for 8 to 12 weeks, as if I'm actually trying to treat that, not just 2 weeks of something to see if it'll help their cough symptoms for a period of time. Mainly because, and I guess one thing is that patients tend to stay on these medications once they feel a little bit better. They think they've got reflux forever, and they think they need to stay on the reflux medications for a long time. And that's also not exactly what we're dealing with. We don't want patients just going to their Costco and just getting recurrent doses of Nexium or Prilosec because they think that's helping their voice. Okay. All right. Now, this was a study from earlier this summer that I thought was really good that looked at the psychosocial burden in patients with chronic laryngopharyngeal symptoms with and without pathologic acid reflux. And so what this was showing, prospective study of patients with LPR symptoms, dysphonia included, and they underwent a gamut of basically psychological testing, and they also underwent a reflux evaluation. So this laryngeal cognitive affective tool, a GERD quality of life indicator, an illness cognitive questionnaire, a voice handicap index, reflux symptom index, a bunch of different things that were looking at how symptoms affect patient psyche, and then they actually grouped them on whether or not they actually had reflux or not. And so they were grouped in GERD positive versus GERD negative patients. So these are objectively defined evidence. And what was interesting before we get to the GERD portion is that stress is really high in patients that have laryngopharyngeal symptoms, like really high. It was like 67%. 2/3 of patients actually had moderate to or moderate to high levels of depression, anxiety, or elevated cognitive assessment scores related to this. This is a heightened sensory area, and they tended to be really distressed when they were having these symptoms. What was interesting in this particular study, 10% with moderate to severe depression, 30% elevated LCAT. Sorry, I forgot to put these numbers in here, and 28% with both. But again, roughly almost 70% of patients had notable symptoms, and only a third had normal or mild psychosocial distress in this. What was interesting is when you looked at it, GERD versus no GERD, they were the same. Didn't matter. Didn't matter if they actually had reflux disease or not. The stress associated with the symptoms didn't really matter. So it made me kind of pause and say, all right, before I just attribute everything to reflux disease and that someone has a heightened awareness of their laryngopharyngeal symptoms, I may need to be thinking about reflux medications alone are not going to fix this, because these patients, although somatically, they're thinking about this regardless. They are having concerns about this no matter what. So whether GERD is present or not, there's still going to be notable hypervigilance and notable anxiety related to their laryngopharyngeal symptoms. So just think through that as we're thinking about every patient that's coming in. I know we want to find an answer for them. We want to treat if we can treat it, we want to, but there is anxiety associated with these symptoms regardless. I wrote in here highlights that non-reflux directed therapies are needed for many patients. Again, these symptoms are present. They are symptom producing, at least from an anxiety standpoint, and we need ways to go after it. So every patient can kind of be grouped in the world of LPR symptoms. Every patient can be grouped into one of three possibilities. They either have reflux disease, they have LPR being the actual acid coming up into the larynx. They could have reflux disease and no LPR, or they could not have reflux disease and not have LPR. So these are the three possible scenarios. Anybody coming in with hoarseness, with dysphonia, with globus, throat clearing, chronic cough, it doesn't matter. Any of those symptoms, they are going to be one of these three worlds, because these are the only three possibilities that's there. When they may not have reflux disease at all, they may not have LPR at all. And you just have to recognize that that is there in any patient that we're treating. So I guess I say that we just need to take a step back, and I see each of these scenarios all the time in my clinic, but I don't rule any of them out just based on presentation alone. I really have to think through, do I think a patient has one versus the other, and how do I get through there? So this is interesting, the study that's very old, but it looked at 57 students from the University of Miami School of Music, and it was incidence of abnormal laryngeal findings in asymptomatic singing students. And so they were just scoping patients and taking a look, and what were they finding? And it was actually pretty common to find abnormalities. And I bring this up because there's always this, all right, well, we can definitely diagnose reflux disease with a laryngoscopy. And there's a lot of intra-observer variability there. And this was actually showing these are asymptomatic individuals, and 61% of them actually had erythema in the laryngeal inlet. 17 had edema, incomplete glottic closure, 84%. Again, I don't know what all these things are exactly because I don't see this stuff, but I do know that these things are probably not necessarily abnormal, but these are things that you guys probably encounter a fair amount, either on stroboscopy or on laryngeal exams. And we're always trying to figure out, what do we need to do with this? Do we need to do something with this or not? Is this just a component of their voice use and their vocal hygiene, or is this actually something pathologic, or is this something that means something more, or if there have been a change in symptoms, we're trying to figure out where they're at. And I thought this was interesting just because it brings up that abnormal findings don't necessarily mean symptoms, I guess is the key point to this slide. This was a slide from, I guess, 10 years ago, a study from 10 years ago that was actually looking at patients with LPR symptoms. Some of them actually had typical reflux symptoms as well, and they went and did their exams, as both laryngeal exams and esophageal exams and reflux testing. And basically they found that not everybody that actually has reflux disease actually had abnormal acid exposure time. In this particular study, only 5 of 41 patients actually had objective evidence of reflux disease on their reflux testing, but 25 of them actually had typical reflux symptoms. They had heartburn, they had regurgitation symptoms, but when you went and you diagnosed or tried to objectively define reflux disease, it wasn't as common as you thought. 11 did have reflux hypersensitivity, and I haven't talked about that yet, but that actually is probably going to be an important thing with you guys as when I talk about laryngeal irritability here in a second. Reflux hypersensitivity is where patients have physiologic amounts of reflux disease. So they're less than 4% in our world of reflux testing, but they tend to still just feel everything that's reflux related. Like their body is just hypersensitive. They feel reflux every time that it happens, even though their amount is considered physiologic. So that's called reflux hypersensitivity. And it's not that their symptoms are made up. It's just that they tend to feel their symptoms more so than patient B right next to them that may not feel the same exact reflux exposure, may not actually feel that degree of reflux symptoms. All of these patients, at least in this study, almost all of them actually had laryngeal redness, but actual esophagitis or abnormal acid exposure times was actually rare. So it brings up that we must objectively define reflux disease. And again, I'm a gastroenterologist talking to you guys, so this is like my wheelhouse of things that I recommend. So yeah, I guess take the things that I'm saying with a slight grain of salt. But again, I do think that reflux testing and actually objectively defining reflux before we just start treating everyone for reflux disease is important. And it's important in our world too. Like this is not just a laryngeal problem. This was New England Journal of Medicine is our biggest medical journal that we have, our most prominent one out of Harvard. And this was a study that's now 5 years old, but this was a randomized trial looking at medical versus surgical treatments for refractory heartburn. And what that means is, so we were trying to, in patients that have persistent heartburn symptoms, true reflux symptoms, we're trying to figure out what's better for them. Is it more PPIs or do they need to go to surgery? And that was the background behind this. And the hypothesis was that if we actually work these patients up and actually try to define who's got reflux disease, who doesn't have reflux disease, maybe we will actually find that not everybody has reflux disease that we think has reflux disease. And maybe their refractory heartburn or their persistent symptoms of whatever's going on here is not actually reflux disease. And that's exactly what they found. It's pretty interesting. This was a study out of the VA, actually. And you can see my screenshot thing that's still there, sorry, that 366 patients were enrolled in this study, a big study, randomizing surgery to medical therapy. But what was the most interesting finding was actually this little grouping here. A third of the patients did not actually have reflux disease. Again, these were patients that were being put in a study for refractory heartburn. And we actually look and actually determine who actually has this reflux or not. A third of them did not really have reflux. And so it made us in the GI world really pause again, saying, hey, we need to work up patients. We need to look into objectively defining reflux more so than just saying, hey, my throat tickles now and this is new and I have a little bit of heartburn symptoms. Before we, again, pursue surgery or high doses of reflux medications, we just need to know that other things can contribute to symptoms. So why is there this discrepancy? Why is there a discrepancy between symptoms and what patients are feeling? And this is a slide in our GI world, and that we know that there are differences between our patients' psychological and cognitive sensory centers, and then also their peripheral sensory as well. And the peripheral sensory here, I'm thinking of GI tract, and we're obviously going to bring this back to the larynx, but we know that certain patients have heightened sensory motor activity in their GI tract. And we call these things disorders of the gut-brain interaction, so DGBIs. And we know that just stimulation from the gut lumen or mucosal injury can basically hypersensitize certain patients to be aware of their symptoms much more frequently than others. We see this a lot in irritable bowel syndrome. I see this a lot in Globus patients, that where blowing a balloon up in their esophagus, Globus patients tend to feel that up high every time, even though you're blowing the balloon up in the very bottom of the esophagus, they always feel it right here in the neck. And there's something off with their sensory. Same thing with irritable bowel. When we blow a very small balloon up in one patient's rectum versus another patient, they have a total different perception of that from patient A to patient B. And it's just their sensory differences between each of our patients. And so that's why there's sensory differences in how patients perceive any of our symptoms. This also gives us some targets of things that we can kind of talk through and teach through with our patient. It may be therapies derived at how they sense things in their GI tract, or centrally directed therapies, which may include biofeedback and actual therapies to actually help patients with the symptoms that they're dealing with. So this is another GI slide that I threw in here that, again, is looking at the pathophysiology of disorders of the gut-brain interaction. But basically, there's psychosocial components, gastrointestinal components, and neurologic components that basically are just changing how our body is dealing with a sensory, no matter where it's coming from, whether it's coming from the GI tract, whether it's coming from the larynx. We know that our body and how it processes stimuli changes patient to patient to patient, and we need to be aware of that. So this brings up the brain laryngeal interaction. And this slide here is I just found as I was reading this, is very, very similar to what I deal with in disorders of the gut-brain interaction. And this is a circular moving, I guess, relationship between laryngeal feelings, laryngeal behaviors, and actually laryngeal thoughts, and how we're dealing with different types of sensory. Okay. And as we kind of walk through this, we know that hypervigilance, perseveration, and anxiety are things that tend to be heightened. I showed that it's already heightened in LPR patients, whether they have reflux or not. And then how they feel things, they tend to have enhanced sensitivity. So on the left side, to any physiologic stimuli, that can lead to muscle tension, dysphonia, or muscle tension dysphagia, sore throat symptoms, globus sensations, and then that leads to different behaviors which can be problematic. And those behaviors are the things where we can hopefully step in voice therapy worlds that actually could be helpful in patients that are having problems, whether that is excessive tension in their voice, whether it's changes in voice quality on how they're feeling and dealing with said symptoms, straining, muscle tension, throat clearing, so aberrant behaviors that we are trying to retrain out of our patients. Chronic cough is a good example too, where every time many of my patients have a throat sensation and they feel like they have to clear their throat, they have to cough because that's what then makes it go away briefly. Well, that obviously is leading to a problematic pattern or habit, which then can cause more problems, including hoarseness, laryngeal changes as well. But we know that these thoughts, feelings, and behaviors are really intricately related. And it's so amazing when I was reading this because it's so much like things I deal with in the esophagus. It's the same feedback loop that is just how our body is dealing with stimuli and stimulation. All right, so what should we do with this, or what are things that can be done? This was a study, or just really kind of a narrative study from APT this summer that was looking at patients that are presenting with chronic laryngeal symptoms. What should we do with that? And on the far left side is actually the reflux related thought process. So if they have typical reflux symptoms, remember I talked about typical reflux symptoms being heartburn, regurgitation. Those are the patients that make the most sense that we should consider testing for reflux disease. And if they have reflux disease, boom, acid anti-reflux interventions, reflux medications, lifestyle diet optimization, adjunctive therapies are all things that can be used to treat if we know they have definitive reflux disease. If they don't have typical symptoms, so they're just presenting with hoarseness, they don't have heartburn, they don't have regurgitation, think of something else first, because the likelihood that a PPI is going to be helpful there. Remember in the slide I showed earlier with the green purple bars, the likelihood that just adding a PPI on for their throat clearing or their hoarseness is going to be helpful is super low. And so we need to look for other types of laryngeal behavior dysfunction that actually could be contributing to their symptoms well before reflux disease is, especially if they don't have the typical symptoms of reflux as well, or concomitantly. Assessing for other etiologies is always a pertinent thing to bring up, whether they need to be seen in the pulmonary clinic, in the ENT clinic, check for sinuses, allergies. This is where a good history is actually really helpful when patients are presenting with chronic laryngeal symptoms, because I want to know, has their voice use changed recently? Have they changed jobs, got more kids they're yelling at? What is changing with their overall voice world right now that actually may have changed? My wife just started back a job at the school system in the last 2 weeks, and her voice seems to be a lot more hoarse the last 2 weeks that she has come home. And so I think it's an interesting phenomenon that occurs, but our voice use patterns definitely matter too. Medications that we're changing or changes in medications, I think, are also helpful things for us to review and look at as we're thinking about someone coming in with chronic laryngeal symptoms. All right. Edie, this is that study I brought up to you the other day, texting wise. So this is, I thought, an interesting study. Also, this was published in our GI journal last month or the month prior. And this was looking at laryngeal recalibration therapy improves laryngopharyngeal symptoms in patients with suspected LPR disease. And so this was 65 patients that were referred for chronic greater than 8 weeks of laryngopharyngeal symptoms. And then the patients were included in this study if they had 2 or more sessions with an SLP for laryngeal recalibration therapy. Now, I don't know if laryngeal recalibration therapy is a phrase you guys ever talk about and or use, but I'm going to at least talk about it because I thought it was neat, and it's neat to my world. But it brings up that reflux medications may not be the best thing for everybody, and so it gives us other avenues of things to think about. So, but this brings up the same thought process of those kind of circular association that I was bringing up earlier. And the basic tenets of laryngeal recalibration therapy are to reduce cough, throat clearing, enhance laryngeal hygiene, restore voice function, regulate breathing, improve swallow efficiency, and alleviate associated cognitive burdens that are associated with this tricky cycle. And so whether it is highlighting cognitive issues or whether it is concentrating on mechanical guidance, laryngeal recalibration therapy, at least in this study, was trying to reduce hyperresponsive behaviors, restore voice function, and regulate breathing, and then also alleviate cognitive burdens at the same time, because we know, as I just talked about, these things are very cyclical in nature. They talk to each other a lot. And so if we can actually make an improvement in how we are perceiving said symptoms, we can actually probably help our overall vocal hygiene down the line. And again, I'm not to even pretend to know exactly what all this is, but I thought this was an interesting thing because as I show the results, actually, we'll get into the population of this. So this was the study population. Laryngeal symptoms were seen in 100% of patients, and 77% of them also had esophageal reflux symptoms as well. And that was heartburn, regurgitation, but 79% actually had dysphonia as one of their laryngopharyngeal symptoms. They all went up. Let's see, 71% were on PPIs. All of them underwent endoscopy, and we are looking for things like actual acid reflux disease. They underwent reflux testing, and 50% of them actually had proven GERD. 30% did not have reflux disease, and 21% were inconclusive, meaning they were between 4 and 6%. They didn't actually meet the threshold for pathology, but they weren't totally normal either. Abnormal video fluoroscopy was seen in 64%, abnormal barium esophagram 71%, and then 11% were smokers. And so of this was the symptom response following laryngeal recalibration therapy. So there was no changes to reflux medications at all, whether they had reflux or they didn't have reflux, whether they had concomitant symptoms or not, but it kind of grouped it by if they had isolated laryngeal symptoms, laryngopharyngeal and esophageal symptoms, and then by their reflux profiles. And so the green bars actually look at response rates to LRT, laryngeal recalibration therapy, and it was pretty good. It was actually really good at actually helping them deal with their symptoms. And that include improvement or perceived improvements in their actual voice and voice hygiene or in voice scores. I can't remember exactly what the score was in this, but whether or not they had reflux disease or not, when they actually grouped them by did they have pathologic reflux or not, even though 70-something% of them actually had reflux symptoms as well, just doing laryngeal therapy actually helped too. Or I don't want to say, I don't, this is not voice therapy, but this recalibration therapy, maybe this is a type of voice therapy. But what that just shows you that we can intervene in a way that helps us or helps our patients actually deal with the symptoms that they're having, and it may be helpful in how they deal with their or their voice changes. All right, last couple of slides here. So this was another study that looked at effectiveness of voice therapy and reflux-related disorders. This was PPI versus voice therapy, in addition to the two. And they underwent a vocal hygiene program and also directed techniques at voice. And I will say in this study, reflux was very poorly defined. It wasn't a great, I can't say this is every single one of these patients had definite objective reflux disease, but they all had symptoms. And their reflux symptom index improved in all patients, but voice qualities did better if they had voice therapy added on top of it alone. So just showing you that a concomitant approach can be appropriate. So how do I approach extraesophageal symptoms of reflux disease? If they have typical reflux symptoms as well, so they have heartburn and regurgitation, far left screen, twice daily PPI therapy for 8 to 12 weeks. If I'm treating, again, it just says I can treat reflux as well because they have heartburn symptoms. If I'm going to treat it, I'll actually do high doses. If they don't have typical symptoms, you've got to do other things first. You've got to go to ENT, pulmonary allergy, other types of things to really determine whether or not we think their symptoms are actually reflux or not, and that should be managed however. If all that comes back negative, then sure, we can go for actual endoscopy to actually test if someone actually have reflux disease before I'm going to commit someone to long and high doses of reflux medications. And this was in one of our GI journals for the management of extraesophageal reflux from just last year, which I thought was a pretty good algorithm as we think through it. All right, key points. GERD is common. Typical symptoms may warrant an empiric PPI trial. Atypical symptoms warrant an evaluation. Since the data is less than conclusive, predicting treatment response seems to be poor in the world of dysphonia. Just want everyone to know that data. Treatment response is better predicted if someone actually has typical reflux symptoms as well. And my last point is that GIs should befriend their local SLPs, because I do think that we can have a good relationship and make headway together for some difficult patients at times. So I will stop there, and someone can look at the question world for me, or y'all fire questions. I'm here to answer whatever I can.
Oh, this was fascinating. Thank you so much for sharing all of that really fantastic information. We do have a question in the chat. Folks can totally add more questions to the chat or unmute and ask. We have a question from Sarah about whether we know if the body habits that reduce frequency or severity of reflux events, or rather the diet that people generally eat in order to lose the weight.
Yeah, good question. So dietary thing, there's a lot of data here and there on that. And actually, there's an ENT in New York that recently sent me a book. I met him at Cincy Laryngology. You guys should go to it if you haven't gone to it before. But it was called the acid reducing diet, or the low acid diet. And it was an interesting book. And I've gotten to like halfway through it actually, because it was trying to determine whether, if we just went to low acid foods, could we change everything? And the thought process being that as acid goes through our esophagus, even though we've got defense mechanisms in the larynx, and we've got actually create the mucosa in the larynx actually creates certain chemicals actually that help break down acid. If there is a barrier, if we reduce the amount of acid that we're eating, can that actually be helpful? In his practice, he's been very, very productive actually at showing that low acid diets could be helpful at reducing laryngeal symptoms in his practice. And he's very, very big on that. The data that I showed you earlier on lifestyle changes, I think, is important because of one of two things. There is not a definite diet out there that's going to take you from erosive reflux disease to non-erosive reflux disease. I actually don't care how many tomatoes that you eat or citrus food. It's not going to change. Either you're going to get erosive changes in your esophagus or you're not. And that's based on other particular factors. It's not a specific diet that's definitely going to change your clear acid exposure. Now, symptoms are different though. If there are definite triggers for your symptoms, and you know that every time you eat tomatoes and pizza sauce and Papa John's or whatever it is, if you know that's what causes your symptoms, avoid those symptoms. Like there's no reason to keep eating said symptoms if they cause symptoms, but there's probably not going to be, you're not going to heal esophagitis in your esophagus by not eating Papa John's anymore.
I guess we're thinking like if like less than like acidic foods, like are the foods that make us lose weight, like foods that are like less processed, like more, I don't know, geared towards a target balance of macronutrients to like maintain a healthy BMI, you know, like it would eating those things, like are people, if people start eating a weight loss diet, do their reflux symptoms reduce before their weight goes down to normal, or is it not until their weight goes down to a normal range?
So interestingly, some people do report that like brat diets or like bland type diets tend to help their symptoms. And we know that weight loss improves reflux. And so, yes, there should be a relationship between weight loss and the diet associated with that and actual improvement of the reflux symptoms. But it's not specifically the diet. It may help symptoms, but I don't think that's gonna change your voice. I really don't think that you definitely changing your diet all around and jumping to a no pickle diet right away is going to be the thing that's going to like definitely fix your voice. Is would be my opinion on that.
I think we have time for a couple more questions. We've got Edie on deck has a question, and then Dominique after that.
Oh, okay. I'll just do this quick. First of all, Jim, thank you for just being so evidence-based and honest in talking about all the things that have caused so much angst for so long. You know, I have two things. My question for you is, one of the things we hear from physicians outside of our center when patients come to see us is that people look at the larynx and they're like, oh, interarytenoid pachydermia, oh, edema, oh, blah, blah. And patients are saying, but I don't feel any reflux. And they're like, oh, it's silent reflux.
Sure.
Is there such a thing?
Yeah. So I will say that when they look at laryngeal findings and when we actually put that against pH studies, the actual ability for ENTs to do that well is actually poor. And that comes from their own data. Just their ability to say that this is definitely reflux related versus this is not, is actually not that good. And you would think it would be, even at very specialized centers, there is still too much variability person to person to person to say that. So I guess my comment to that is, I don't think we're that good. And they say a pachyderm, that does not clearly mean acid reflux disease, that we should go on high dose reflux medications. Now, especially when it comes to therapies past 3 months, because again, if an ENT and wants to put somebody on a reflux medication for a period of time to try to help with said symptoms, sure, I'm fine with that. But before I commit anybody to long-term PPI therapy because of their whatever redness in their larynx, I would really want to justify putting someone on that type of therapy. Now, could there be silent therapies? And I do think that there is a clear difference between how patient A and patient B senses reflux disease. And I did mention at the very beginning that 50% of patients with esophageal cancer don't have reflux symptoms. I know that silent reflux exists because patients, or they don't recognize it. They don't recognize whatever symptom they have or sensations they have is actually reflux disease. There's either a perception problem or there is like a cognitive disconnect on what symptoms are that so I do know that reflux is silent enough when you ask esophageal cancer patients, which we know comes from reflux disease, that they don't have reflux symptoms, never been on PPIs. There has to be something else. There has to be something there that says that patients cannot perceive their symptoms. So part of that is, yes, silent reflux can be positive, but laryngeal findings alone without typical reflux symptoms, it just makes me, take a step back and pause and say, all right, do I really think that's what it is if they don't have typical heartburn symptoms at all?
Thank you.
Yeah.
Great. Let's take one last question. Dominique.
Yeah, thank you. Thank you, Dr. Callaway. This is very interesting, especially for me, who I have been experiencing almost everything you've been talking about for the last 9 years. I've been diagnosed, excuse me, I'm French. I've been diagnosed with reflux 9 years ago, and I'm taking PPI twice a day, 40 milligrams, and I've developed a chronic cough since then. But since the last 3 years, we've been investigating a lot to try to understand, and it seems it's a consequence of reflux. And I'm on the edge of having an operation. I have an appointment with a surgeon. My question is, the PPI I'm taking at pantoprazole twice a day for 9 years, and my doctor tells me that I should be taking that medication for my whole life. Do you think, what do you think of that?
Yeah, good question. Yeah, so basically the crux of the question is chronic PPI use, is that recommended, and how detrimental could that be, really, I think is kind of your question. The short.
I must say I have Barrett's esophagus, and it went from that to a baby Barrett.
Yeah, so
it helped.
that
It seemed
changes.
to happen.
Yeah, that changes in your world a little bit. So reflux, you have objectively defined reflux disease.
Yeah.
So Barrett's esophagus is, as I mentioned, a potential precursor to something problematic, and so it has to be looked at periodically. But in the world of your symptoms, or I guess the question of chronic high dose PPI use, it only needs to be used in where it's helpful. So if it's shown benefit in your symptoms, then it's a medication that I would consider to be used chronically. At the same time, the vast majority of patients can be reduced to once daily or even 20 milligrams daily. The vast majority of patients can actually get down to lower doses once acid is suppressed, and don't need really high doses for their entire life. But in those patients that do, that's where we start thinking about, well, do I want to take a medication that has potential side effects? And I will say the American College of Gastroenterology, this is a question we get a lot on. Chronic PPIs, are they going to cause my magnesium to be zero, my B12 to be low, and my bones to break? And the short answer is, those are actually very similar to the voice studies. They are all association type studies, but they have not proven causality. The only thing that we have kind of causal data on is actually GI enteric infections. So like chronic PPI users tend to have more bouts of GI illness actually than those that don't. But the actual other studies, hip fractures, all-cause mortality, or chest pain, or cardiovascular disease, those are actually association studies, and they haven't proven causality. I'll take a look at it on, does the patient actually have a bona fide need to be on a PPI for long term? Barrett's esophagus is one of those things, though. It's one of those few conditions that we say, hey, this patient should be on a PPI for life. And even if they undergo surgery, they still need surveillance to be looked at. The surgery is not the end all be all for all reflux, unfortunately.
And if I can just add one last thing, is that I always have that feeling of mucus in my throat. Yeah. And I have, my voice is changed. I'm a voice teacher and a singer, but I know my voice is changed. But I experienced something interesting 2 weeks ago. I went to my Otolaryngologist, and she examined my vocal folds with a camera, and she could see, and she showed me that I had no mucus on my folds, and it was just inflammation on my arytenoids and the basis of my epiglottis, and that made me feel that I would have mucus.
Yeah, no, it's quite common. We don't know, our body is just not really good at perceiving things really well here, or actually in the chest as well, which is, I mentioned that Globus study where Globus patients tend to feel things in a different location from where the actual stimulation is going on. And so it's just super common problem that we don't fully understand.
But then I will clear my throat. I will want to clear my throat, and it's no use for that.
And then it's a bad cycle. Sure.
Yeah.
Sorry.
Thank you.
Yeah, absolutely. Any other questions, or is that it?
There is one quick follow-up that's actually related. What about the alginate-based treatments for long-term use?
Yeah, so we don't have data. I'll say we don't have great data. Actually, all the alginate studies that are out there are actually really short. They're like less than 4 weeks. So we do not have We do not have studies on the safety and efficacy. They're felt to be inert subjects that are not really absorbed at all. And so because of that, they're not felt to really cause bodily systemic effects overall. So probably safe long-term is what would be my comment, but we don't actually have great science to document that.
Fantastic. Thank you so much. Thank you all for being here and attending this. We hope to see you again at our next event in October. Keep an eye out for that. And we hope you have a wonderful fall as many of you are heading into a school year or a new academic year.
Sure.
Thank you so much, Dr. Callaway. We appreciate you.
Absolutely. Thanks for inviting me.